Everyone, and welcome to the Schwarzman Animal Medical Center's 10th annual One Health Conference, hosted by the Anne and Charles Johnson One Health Institute. I'm Nicole Liebman. I'm director of the Cancer Institute, service head of oncology, and oncology program residency director at the AMC, and so fortunate to have spent my whole career here. It's not over yet, hopefully, and I'll be moderating tonight's event. This is day 2 of our conference where we are explaining a comparative approach to cancer diagnosis and treatment. After tonight's talk, we will take questions from the audience, which can be submitted through the chat box. And as a reminder, at the end of the event, please click the link in the chat or scan the QR code to submit your form for CE credit. Tonight, we will be discussing the comparative oncology and translational aspects of oral tumors in human and veterinary patients. I'd like to thank our speakers, especially Dr. Jay Neugarten. Thank you so much for donating your time and helping to support animal health in this One Health arena. And Jonathan Ferrari for joining us tonight, my colleague. Dr. Neugarten is a graduate of the Columbia University School of Dental and Oral Surgery, where he was named class valedictorian and earned membership in the National Dental Honor Society, Omicron Kappa Upsilon. He completed his residency at North Shore University, Long Island Jewish Medical Center, and earned a medical degree from the Stony Brook School of Medicine. Dr. Neugarten is the oral and maxillofacial surgical member for the craniofacial team at New York Hospital Cornell Weill Medical Center. He is a nationally known specialist in oral and maxillofacial surgery, whose areas of expertise include working with patients requiring both complex implant and bone grafting construction, as well as with those whose skeletal, facial, and craniofacial deformities require corrective jaw surgery and distraction osteogenesis from neonate to adult. His other areas of specialization include temporomandibular joint reconstructive surgery, dentoalveolar, and complex reconstruction surgery using the most advanced surgical technology. Dr. Neugarten is a fellow of the American College of Surgeons, an educational association whose physicians must pass a set of rigorous qualifications for membership. He's an associate clinical professor at both New York Hospital Cornell Weill Medical Center and North Shore University Long Island Jewish Medical Center, where he's an active educator of oral and maxillofacial residents. Dr. Neugarten lectures both nationally and internationally on a variety of topics of oral and maxillofacial surgery. These topics include distraction osteogenesis from the neonate to the adult patient, implant reconstruction, orthognathic, and craniofacial surgery. Dr. Neugarten's attention to detail and philosophy of providing quality care to his patients with the least amount of surgery has earned him trust from patients and confidence from referring doctors. Okay, on to Dr. Jonathan Ferrari. He came to the Schwarzman Animal Medical Center by way of Philadelphia, having graduated from the University of Pennsylvania School of Veterinary Medicine in 2017. He completed a one-year rotating internship in small animal medicine and surgery at AMC here and continued on as a resident in surgery, where he was the Kovner surgery resident. Following residency, he completed a fellowship in surgical oncology at the Colorado State University Veterinary Teaching Hospital. And then we lured him back, and we're so lucky to have him. He is certified as a diplomate of the American College of Veterinary Surgeons in small animal surgery and a fellow in surgical oncology. He is committed now to providing comprehensive care for dogs and cats with cancer and pursues clinical research to better treat patients fighting cancer. Beyond veterinary medicine, he enjoys cooking, running, and attending theater and music events in the city. A big thank you to both of you. We look forward to hearing your talks tonight. Okay, Dr. Ferrari, you can take it away.
Excellent. All right. Thanks so much for that introduction, Dr. Liebman. And yes, thank you, Dr. Neugarten, for being here and everyone for attending as well. I know in our audience today we have a range of participants, both veterinary technicians and veterinarians, and amongst our veterinary group, we have veterinarians in general practice as well as some specialists. So hopefully our talk can be relevant for any participant in all levels of veterinary care, as well as some information to share with any families with diagnoses of oral tumors as well. Let's see, here we go. Great. And so since I know that the phrase surgical oncology isn't as common in the veterinary field as it is in the human world, I wanted to share a little bit about the kind of the goal of this term, this fellowship, if you've heard of that before, and kind of my role at the Animal Medical Center as a part of the oncology team and the surgery team. And basically, a surgical oncologist focuses, of course, on the surgical management of cancer patients, and kind of working together with the medical and radiation oncologists to formulate a multimodal approach. I think it's really important to know that, of course, surgeons across the city, across the country, who have specialized in general surgery, perform surgical oncology every day. The role of this kind of particular niche or subspecialty is really just to focus on surg-onc cases in particular and be available, be around, and be part of the conversations kind of before surgery and afterwards to select the or select the appropriate time and the appropriate cases that go to the OR. Are we thinking about doing either preoperative or postoperative radiation therapy or chemotherapy for a patient? And what are our goals of the overall comprehensive plan, rather than trying to figure it out after some sort of treatment has already been initiated? And so just a little bit of a summary of how we're going to uh, talk about this type of problem today. We'll talk briefly about some diagnostics whenever you find an oral tumor, and then about the different differentials for oral neoplasias, as well as a bit on treatment and potential some future directions for where the field is headed as well. So, of course, as you all know, oral tumors come in many shapes and sizes, and it's really common that we find these tumors during routine dental cleanings. So they're often incidental findings where patients say, hey, my or sorry, clients say, hey, my dog has no problems at home. What do you mean you found something in the mouth while you were cleaning out the teeth, right? Thought this was just a routine cleaning. And that's why these photos are shared with my colleague, Dr. Martel, our one of our dentists here, because of course it's very common that the dentistry team finds these tumors, as well as referring veterinarians who find these tumors during routine dental cleanings. A very reasonable first step while you have a patient anesthetized and you find a tumor like this, is to take some dental radiographs. Of course, that's very commonly available to you at that time of diagnosis, and it can help us to get a little bit of an idea about what's going on underneath. Are we seeing any lysis of the bone, or is it like this photograph where we're seeing kind of a mineral dense tumor kind of originating from the bone? That can kind of help provide some clue about what type of tumor we're talking about, as opposed to a tumor where we might be seeing some lysis or loss of normal bone architecture underneath. Now, obviously, the detail on a dental radiograph is going to be a little bit less than that for a CAT scan, but it can help us kind of get a general picture that, what you're seeing on the outside of the tumor is not always what's going on underneath the surface. And of course, that can range to the very severely lytic tumor, like this one, where you have your normal side of the jaw on the right side of the screen, and then on the left side of the screen, you have an osteoproliferative and lytic lesion that has really kind of effaced the majority of that normal bone of the mandible there. So when you have a patient under anesthesia, you find this tumor on accident, a very reasonable next step that we do is perform biopsy, number one, because we're there. Number two, it's our most helpful tool for diagnosis of these tumors. The most important thing to remember is taking photographs before you take a biopsy, because oral tumors are, of course, originating from the mucosa of the mouth, and the mucosa tends to heal very well. It doesn't leave a robust scar necessarily, especially depending on what size of the tumor we're talking about. Usually these, or sometimes these are smaller tumors where you're ending up just kind of removing the entire thing as an excisional biopsy. And when we do that, then we don't really know where the original tumor was, for us to go back and do a revision surgery or make a plan. And so it can be very helpful to take a photograph before you do the biopsy. That way, if you do have to remove the entire thing and it does not leave a massive scar there for us to find later on, at least we've got a photograph so we can know where this originally was and have a conversation. And that's the reason why the excisional biopsy is not usually recommended. That's why I mentioned it there, because there shouldn't be too much anxiety about, oh, I have to remove as much of this as possible. Just get a tissue sample and let's make a comprehensive plan afterwards, because depending on what our biopsy diagnosis is, we might want to think about a wide surgery, we might want to think about radiation, and depending on what's done with the first cut or the biopsy, that can kind of complicate things if a surgical scar extends in one direction or another, or if it removes the entire thing and we don't know where it is or where it was originally. Another very important thing is that if the tumor is in a location where you can feel it from the skin, and look inside the mouth and find it, always choose to biopsy from the mouth. Do not biopsy through the skin. It leaves a tract of contaminated tissue that we have to remove. With our surgery, and it gets much more complicated than if you're able to just biopsy it from inside the mouth. That's always going to be the preferred route of biopsy, so that way we don't contaminate the skin. Um, and something else to think about is that after you get your biopsy results, occasionally what will happen is that the lab will say, hey, I'm glad you got a tissue sample, but I'm not able to tell what this is. They'll give you kind of this indecisive, wishy-washy report where it says, it looks like a poorly differentiated tumor or something of the sort. Um, and we need further steps to figure out what that looks like. One test they often recommend is called immunohistochemistry, which is special stains they add onto the histopathology slides, and can be really helpful for them to differentiate the tumors. And obviously, that makes a big difference for our treatment plan. One challenge with this type of test is that it takes a little bit of time to get back. And if the owners are at all interested in knowing what the diagnosis is and having referral, it's really helpful to get that moving along before referral. So that way we can have that diagnosis by the time of an appointment. And so if you get a report like this, the owners are motivated for treatment, go ahead and request that immunohistochemistry so we can get rolling, especially because sometimes it takes the lab a couple of extra um, rounds of IHC in order to diagnose the tumor officially if they don't have an answer with their first round of stains. So sometimes we're waiting weeks to get final results back because of a couple rounds for these. So it can be really helpful to kind of get an answer going pretty quickly. Um, oh yeah, this is just talking through kind of the different differentials that come up when we see these kind of indecisive biopsy results and why it's important to get the pathologist to add on that IHC. And the reason why all of that matters is that obviously the local behavior and the distant behavior for tumors is going to be really important. So the local behavior varies a little bit based on the type of tumor, ranging from bone lysis to the potential for fracture, pain, ulceration, or bleeding, of course, in the mouth. And our primary treatment modalities for tumors in the mouth itself for the local disease are surgery and radiation therapy, of course. And then the distant behavior is the other way we think about malignant tumors, and that's, do we have a high or a low risk for metastatic disease? And what sites are at risk for metastatic disease should it happen? Are we talking about the lymph nodes primarily? Are we talking about the lungs primarily, or other distant organs? And in cases with a high risk for distant disease, we think about chemotherapy or immunotherapy in some cases. There are a couple different differentials, of course, for benign oral tumors, a whole different, or sorry, plenty of differentials under kind of the odontogenic tumors. The most common or perhaps complicated of the benign tumors that we treat is the acanthomatous ameloblastoma, which of course is a non-metastatic or kind of what some folks think about as being called benign tumor. But, how benign is it if they're very locally invasive, can cause bone lysis, can cause some discomfort too, and is best treated with wide surgical excision? I think that language can be confusing for owners, benign versus, locally aggressive, but distantly non-aggressive, which is great news, of course, but just something to consider in kind of the language that we use when we talk about it with owners. Why the heck am I coming to a surgeon for a benign tumor, right? Of course, that language is correct. It's just kind of logistic challenge to just kind of explain to the owners the difference between the local behavior and how it can still act aggressively locally, but it's not going to spread. So let's treat your tumor appropriately. And then how about for the malignant tumors that we see? In dogs, the most common malignant tumor in the mouth is malignant melanoma, of course, with a relatively high metastatic rate. Most likely sites for that spread are the lymph nodes in the lungs. And then squamous cell carcinoma is kind of our second most common tumor, with a lower metastatic rate, but it's still possible with the sites of predilection being the lymph nodes in the lungs. And then we have a smattering of other tumors with the sarcomas being represented, fibrosarcoma and osteosarcoma being kind of our two big differentials for sarcomas in the mouth. Um, and important to know that that metastatic rate is pretty variable, um, with fibrosarcomas having a kind of scale of how aggressive they are and that rate for metastatic disease. And osteosarcomas having somewhat of a predictable metastatic rate. However, in general, we think about oral osteosarcoma potentially having a lower metastatic rate and potentially a better prognosis than appendicular. Obviously, we're sometimes watching our language and how we talk about that with owners because osteosarcoma is still osteosarcoma and has that potential for being aggressive distantly. We typically still recommend chemotherapy for it. So, something that we can think about as very reasonable to treat, but we're always, a little bit uh, um, guarded just in the way that we talk about it with owners, just to not kind of get their hopes up. And in general, kind of our workup for these tumors, once we know that this is a malignant tumor, pretty standard. We're making sure we're screening for kind of our systemic health. We're taking a biopsy, we're doing chest x-rays or CT scan of the chest and abdominal imaging just to screen for any other abnormalities in the abdomen, since a lot of these patients are older patients and could have comorbid lesions, either a splenic tumor or renal disease or something like that. So we're always on the lookout for kind of the pet's systemic health and any other lesions that might be involved or might be related to the primary tumor or might be completely unrelated as well. The reason why all of that matters is that the stage of the patient kind of dictates the prognosis for some of these tumors, of course. The stage being kind of the clinical status of the patient. Do we have evidence of disease in the rest of the body, either the lymph nodes or the lungs? So a staging scheme for malignant melanoma has been described where the lymph node status, the size of the primary tumor, the presence of distant metastasis, meaning to the lungs most commonly, um, kind of dictate what stage of disease these patients are considered. And that kind of dictates the prognosis that we can anticipate in the way that we talk about the prognosis with the owners. The lymph nodes in the neck, we're talking about the mandibular lymph nodes, of course, and the retropharyngeal lymph nodes. Now, these can be a little bit challenging to assess, retropharyngeals, because they're kind of deep and next to the larynx. Mandibulars typically are there for you to palpate pretty easily, and very reasonable to get a lymph node sample aspirate if you're able to, while you're working up a patient with this sort of a problem. Usually with retropharyngeal lymph nodes, you're looking for ultrasound-guided FNAs. And it's important for us to evaluate all the lymph nodes because there is crossover in the lymphatic flow from the left to the right, sides of the mouth to the neck. And so it can be a challenge to say, I know exactly which lymph node is going to be the first draining lymph node or the sentinel lymph node. That kind of is the one screening the lymphatic fluid from the tumor and the one for us to sample. So if we're feeling lymphadenopathy anywhere, then we should be sampling that because even if it's on the right side of the head and neck, it could be coming from a left-sided tumor. So we just want to be aware that there's 4 different primary lymphocentrums that drain the head and neck. And of course, all of that matters because a couple of different prognostic factors have been identified for oral tumors, with tumor type, of course, being very important, and then location being important too, where a rostral location is reported to have better prognosis. And oftentimes we think it's because the caudally located tumors are more difficult to identify until they're larger because they're in the back of the mouth. The dogs might not be having a problem until they're quite big, whereas the rostral ones, the owners might be able to see at home. So we can intervene while they're smaller. And we have better surgical options for the rostral ones than the caudal ones, just based on the size and the location and the complexity of surgery, of course. And then a prognostic factor that's been identified as well is also kind of what type of surgery do they have? You know, are we going for a wide surgery where we're aiming for complete histologic resection, meaning no microscopic cells left over? Those patients have potential better prognosis than the patients who have incomplete resection for tumors in general, which is why we think about wide surgery at all. So just a couple examples, you know, here's a tumor located at the front of a dog's maxilla on the left there versus the caudal oral cavity of this cat. And you can imagine with that rostral maxillary tumor in the dog, we probably have a pretty robust surgical option for that with a rostral maxillectomy versus this caudal oral tumor in this cat that, you know, it's difficult to know exactly where that starts and ends. What is it effacing? Is it involving just the mandible? Is that affecting the maxilla as well? That one's going to be much trickier to plan, and that's why the location for these tumors is pretty important for us deciding, or for us, you know, creating and crafting a treatment plan for these pets. And so based on the location, that's kind of how we can plan out what type of surgery we're able to do. There's plenty of different kind of conformations of surgery that have been described. And really we kind of choose the conformation based on the location of the tumor, the CAT scan evaluation for assessment of any bony lysis, and then of course kind of our plan for surgery. You know, what's our goal of surgery? Are we aiming for a wide resection? Are we aiming just for marginal, followed up by radiation? And we kind of plan what type of surgery we're doing based on that comprehensive plan. Um, I think perhaps I might be running out of time to complete my section, but I think that's all right because I really just wanted to introduce these concepts and mention kind of our workup for these patients and the important steps in identifying them and getting them prepared for referral. So I actually might pause there to allow Dr. Neugarten some time to present his information, and then we'll have time for kind of conversation. I can fill in any gaps from what I've paused here for.
Can you see my slides now?
Yep, we've got you.
Great. Let me see if I get play here. Let me come out of this and let me come back in again. And why isn't this allowing me to play? Here we go. Okay, we can see that. Great. Well, thank you, everybody. Nicole, thank you. This is certainly is an honor for me. Love coming across the aisle. This is the first time that I'm coming and giving a human side to veterinarian group, and it's certainly a pleasure to be here with all of you tonight. And I'm really looking forward to this. John, it was nice to hear your talk and some of the synergies and some of the differences on the human side versus the dog or the cat side. Um, First of all, who am I? And Nicole, you did a humbling introduction to me. And I'm at Cornell, as Nicole had said, as well as North Shore. This is my work life and my people life. I'm in private practice with academic affiliations at Cornell, and one of 7 surgeons in a group called NICOMs that has 3 offices, one in New York City, and 2 on Long Island. And then this is my wife and my family when I'm not working. Certainly want to thank them for all the support that they do for me. Wait, why isn't this not going forward? Okay. So this is my team in the office as well as my residents at Cornell. So, you know, oral cancer is in itself can arise really anywhere in the mouth, in the maxilla, in the mandible, in the soft tissue. One of the our main findings is a squamous cell carcinoma, which, as I know for cats and dogs, is the osteosarcoma. So totally contrasting where we see squamous cell lineage, which can come really in the oral mucosa, the lips, the tongue, the soft palate, the pharynx, floor of mouth, and cheeks. Um, and the squamous cell really come from the squamous lines of mucous membranes that will affect the lower lip and the tongue. But also the second most common, believe it or not, is the verrucous carcinoma, and from the salivary glands, and even lymphomas is a big group of carcinomas that we will, or malignancies that we will see within the oral cavity. Overall, the second most common would be basal cell from the skin lineage, but in the mouth, it's verrucous and then salivary glands and then lymphomas. It accounts in the US for about 3% of all cancers per year. There's about 60,000 malignancies within the oral cavity per year, with a lifetime risk of 1 in 59 males versus 139 females. So clearly, it has a sexual predilection of males over females, two times almost with females versus females. And it's typically, we find it in over the age of 40 years old. And the non-Hispanic white, non-Hispanic American Indian, and the Alaska Native people have the highest incidence of malignancies within the oral cavity. And a lot of it is from what we do, smoking and alcohol being the biggest precipitant factor and risk factor for predisposing one to oral malignancies, with almost a 10 to 15 times association between these carcinogens that we see, whether it's alcohol or tobacco use, whether it's chewing, cigar, cigarette smoke, pipe, or snuff. And obviously, dogs and cats are not doing that. But one of the interesting things is what would be the incidence of these animals within homes that have smokers within that? Aren't they seeing a higher incidence of malignancies within that subset of families that are have those within the house? HPV, human papillomavirus, is also another etiological source for malignancies within the human substrate, and ultraviolet radiation. From a global perspective, when we look at the incidence of cancer Taiwan is number one, and Papua New Guinea is number two, and then it goes on down from there. Now, is that because there's a higher incidence of tobacco use and smoking? And certainly a lot of that is causation for that. And if you look at the US, we're towards the bottom of that, right? Which we're more, we got the Czech, and then Cambodia, Brazil, Spain, and then the US in terms of this per 100,000. So interesting that it does have, a country basis as well. And much like John was talking about, there is a staging classification, which we use the TNM classification as well with for staging them. And then we talk about lymph nodes that are involved and the size of them, and then ultimately Mets being one of the more prognostic indicators for overall morbidity and mortality. So what we end up seeing in the mouth are white lesions, and we call them leukoplakic lesions. And you could see a leukoplakic lesion doesn't mean it's cancer, but we see white lesions all the time. And I would say that that's the number one referral that we see as an oral maxillofacial surgeons. There's a lot of white lesions. You go to the dentist, and the hygienist or someone happens to be looking in the mouth, and they see a white lesion or they see a red lesion. And the amount of referrals that we'll see for these white lesions is pretty big. And it could be just from something rubbing. And oftentimes it's a hyperkeratosis, where it's almost like a callus that you get on your hand, where it could be somebody from biting their cheek or biting their tongue. And ultimately, the precipitant factor of doing that repetitively gives this hyperkeratosis, or this thickening of the keratin, which ultimately, when we biopsy, it comes back as just a white lesion. That's that. But certainly red lesions or white lesions when you go to the dentist are pretty concerning. Are not concerning, but certainly one of the things that people identify. An ulcerative lesion can often be indicative of that, but that's also could be trauma, where you bit your tongue. A non-healing ulcer is certainly one of the more common things that we get concerned about, that has a level of induration. When we're looking at throat cancer, certainly we see a sore throat, voice change, difficulty swallowing. Late symptoms would be dysphagia, difficulty swallowing, and pain. So much like, your my colleagues here, we do the same thing: a history and a physical exam followed by a biopsy, whether you do an incisional biopsy or an excisional biopsy. Love the idea of taking photos to be able to document that, which John was talking about before. We use toluidine as well as a screening test, and one of the things that we use also is a brush biopsy. So if I have it in an area that's aesthetic, I'll do a brush biopsy, a little cytology, where I'll take a brush and I'll get cells off of that and then have them look at it under a microscope to see if there are actually malignant cells within that. If there is, then I will do a biopsy. But if I see someone on the lip and they're very concerned it's an aesthetic area, and we don't want to go ahead and do an incisional biopsy in someone's lip because of the aesthetic concerns that they would have. For me to take a brush biopsy and do a cytological smear is really easy. Brush, 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 brush. We put it on a slide, send it off, and they'll look at it under a cell. And if I see, dysplastic or neoplastic cells, then I have to biopsy it. If it just comes back as something else, then obviously we can continue to watch and observe that. And not to get into the grass, but it's deep weeds here. There's three approaches, which is much what you were talking about, John, before. We either have surgery followed by radiation and followed by chemotherapy, based upon the stage classification, and ultimately determining what we're going to do and how we're going to approach these cancers. Whether we can take them out with just an en bloc, or do we need more neck dissections, radiation, and we'll present these at tumor boards and go through a whole algorithmic approach, which I'm not going to bore you with tonight. But excision of the primary tumor, or do a mandibulectomy, which is where we do a resection, hemiglossectomy involving the tongue, radical neck dissection, where we'll come into the lymph nodes in the neck to kind of get those cleaned out for us to give further staging, sometimes down to the neck, and then doing skin grafts as we need to. From a chemotherapy perspective, again, a lot of this is protocol from our oncological colleagues, where we're using 5-FU methotrexate, cisplatin, carboplatin, and onward from there. Here's an example of a 49-year-old male. Now, me on the team, my role as an oral maxillofacial surgeon, some oral maxillofacial surgeons are trained to do oncological ablative surgery. Mine is more supportive. I work with head and neck surgeons and plastics, where we'll do a lot of the mandibulectomies and the resection, and then the microvascular free flaps will be done by the plastics or some of the head and neck colleagues. But here's a tumor in the left mandible that I will show you. One of the other things that we'll do, because there's a nerve that runs in the lower jaw that brings sensation to the lip, and some of these people want to be able to keep that sensate afterwards. Here's a 49-year-old male with an erosive lesion, and the mandible comes back as squamous cell. And when we look at the panoramic radiograph, we can see there is some radiographic changes within the screening X-ray. And the plan here is to do a resection, and we now have evolved using technology where we can plan the resective mandibulectomy and the reconstruction primarily, and then do a fibula free flap, where we'll take a piece of fibula from the leg to reconstruct and bring up a soft tissue paddle, a hard tissue paddle, and then microvascular, bringing us blood flow, which would be important, especially if many of these people are beginning radiation therapy right afterwards. We don't have to wait for ingrowth of blood vessels. We can begin the radiation therapy shortly thereafter, because it comes with its own composite flap and blood flow. This is an example of some of the technology that we use today with these cutting guides. Some of them, which these are prefabricated. This happens to be a metal. Some of them are out of nylon that we're using, and this will allow us to be able to make our cuts within the jawbone. And here's a resective component of a mandible, and that hole that you see with that yellow line is where the inferior nerve happens to be. And we ended up doing a pull through, because if we don't have perineural invasion, which we typically don't with squamous cell, we can pull the nerve out and then do a reconstruction. This is oxygen. This is a nerve that comes from cadaver that has been harvested, that allows us to then do nerve reconstructive and microvascular surgery and reconstruct the nerves here, which we routinely do for these kind of ablative surgeries, to be able to get some level of sensate or protective response to that lip after surgery. And this is what the x-rays will look like with the fibula in place, with the flaps that we bring up. So we bring up its own hard tissue and soft tissue to reconstruct the mandible, so that we do not leave them with a continuity defect. And somewhat we can return them to function, to be able to chew and speak and swallow, to be able to get them into a quality of life in the presence of this, debilitary disease. And this is what this person's postoperative result looks like. Post-surgery, you can see the neck flap and the skin flap here. I want to pivot a little bit into talking to, and I was talking to, Dr. Ferrari about this before. John, and you and I spoke about this, and I want to introduce this concept that we see in humans, which I don't believe you see within the veterinarian side, but we have a number of patients that either have multiple myeloma and breast cancer that we have noticed beginning in 2001, where we see this exposed bone within the mandible or within the maxilla. Which and my partner Sal Ruggiero was one of the people who really was in the forefront. This was in 2004, where this got published, where we see this exposed necrotic bone, and it looks almost like a malignancy. I mean, it looks, and it's or like necrotic bone, and it became apparent over time that this was related to osteoclastic medications that we give, Zometa or Rydia, for patients that have bone pain. And we don't see this systemically. We don't see this in the long bones orthopedically. We really only see this in the jaws. And here's a 74-year-old female with stage 4 cancer, 2-year treatment of Zometa, which is an IV form of Fosamax or Boniva. And ultimately, they then came out with Prolia to be able to use as an injectable for people with osteoporosis, but much less dose than the Zometa. Zometa is a very high dose that they're giving for patients that have Mets. And this is what the postoperative result that looked like. And what I want to show you, because it's even become bigger, here is a patient that we see with these cutaneous lesions on Zometa, 2-year history. And we look at the necrotic mandible in the lower picture with all this radiolucencies, and it looks very, invasive. It looks almost like a malignancy when you would look at that on a radiograph. And these are necrosis of the jaws. These are not malignancies, but these are actual necrosis that has been developed as a result of these osteoclastic inhibitors. And here we're doing a primary reconstruction. And I want to kind of get into the why. Like, what has this been developed? Because we've been seeing this now for the better part of 24 years, 23 years, we've been seeing this. And what happens is you get an osteoclastic suppression from these drugs, which then we see an inflammatory response. And in the mouth, the mouth, as we know, is dirty. It's the only place in the mouth. All the other long bones they don't have the bacteriological involvement that we see in the mouth. And there's a vascular component, there's immune dysfunction, there's a genetic component. But ultimately, it is multifactorial as to why we see these necrotic lesions within the mouth. And this kind of gives you a little bit of a workflow here where you have normal soft tissue and osseous periodontal structures that leads to inflammation, which can get periodontals, and then you can get extraction. That's traditional. But what's happening in these MRONJ, and it stands for MRONJ, medication-related osteonecrosis of the jaws, is medications, whether it's bisphosphonates or even denosumab, we're seeing this with as well, where we're seeing this necrosis of the jaws. And our organization came out for stratifying these approaches for how to manage these. And the reason that I brought this here tonight, and I wanted to kind of have an open discussion with you, Nicole and Jonathan, is do you see this in the subsets of animals, whether it's the cats and the dogs? Because this is not cancer, but certainly does it cross over to that? And with that, I say thank you. Certainly a lot of contrasting styles in terms of the malignancies that we see. But, this concept of reconstruction, is that something that's typically done in the dogs and cats that you take care of? Or is it more ablative surgery, or is it more radiation? And obviously, it's really family decision, which is what you were talking about before, Jonathan. But how do you guys handle that?
This is fascinating. I'm really, it was riveting talk, Jay, and Jonathan. So I'll chime in and then we can take some questions from the chat. But I would say, and Jonathan, chime in here, please. But, we certainly use bisphosphonates. I use bisphosphonates mostly for pain, for bone pain, for bony met pain, bony metastases. We don't really treat, we don't treat it as, it's not a preventative. We don't see the diseases that people have where they have osteopenias or something like that, where we're using bisphosphonates in that arena, but we certainly use them for bony pain. But these are animals that have end stage disease, so they don't live long enough to develop osteonecrosis of the jaw or anything like that. I know it's a very serious, but what I understand, I mean, obviously you see a certain subset of patients, but in the realm, it's the percentages are still fairly low for people that receive bisphosphonate therapy for yes,
So
no.
yes, yes, yes. On the oral side, osteopenia, osteoporosis, the incidence is less than 0.1%. It's very, 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 very tight, very, very tiny. But on the IV bisphosphonates, for those which you just spoke about, Mets with bone pain, someone has multiple myeloma or they have breast cancer and they have metastatic disease, the oncology colleagues are using it for bone pain, for exact that person. I've got severe back pain, I've got hip pain, and they're seeing these Mets. And they're using Zometa, and already I had someone get 2 dosage of Zometa and necrosed the maxilla, literally on 2 doses.
Are
Gloria,
these
she
are these people on supplementation? Are they, is there any relationship with not, having enough calcium, vitamin D associated with receiving these medications?
so what we see is those patients on steroids.
So
Steroids
they're
are
already
have
predisposed.
yeah, so the steroids and these medications, but this was an evolution for us. I mean, this came about in 2001. And our specialty really did not know. We've kind of evolved through this through years. And now AMIS, which is our national association, we've got guidelines. And when patients are going to go on these medications, they're getting to the dentist, they're getting screening examinations, we're seeing their periodontal, and they're understanding the risk factors that are associated. Because at the beginning, nobody knew. We didn't know this even subclass came about. The patient that came and saw me came from their dentist and they said, "Yeah, I need you to see this patient. They've got calcified plaque on their maxilla and I can't get it off." It wasn't calcified plaque, it was dead bone. So, yeah, I mean, on the orals, very low, very, very low. But on the IV forms of it, a much higher incidence. And one of the biggest things that we also see is prolonged exposure of it. And much to what you're saying, the animals you're seeing, they're not living long enough. So, and how long are they willing to make this financial investment, personal investment for their loved animal to be able to get to that point? So it might cross over, but we're not just seeing it because of the longevity.
I think that's probably true. They just don't live long enough. But so you're saying this is probably dose dependent and not idiosyncratic. You think that,
Correct.
hmm,
Dose and
interesting.
time, and also inflammatory, and it's multifactorial. I think it's dose, time, genetic, multiple medications are they on? Are they on steroids? Are they on? Because some of these patients that, especially that are on long-term steroids, have even a higher incidence of it.
Hmm, interesting. So you said something earlier that I wanted to comment on. You talked about exposure and what causes these tumors in cats or dogs. And cats specifically, they groom, right? Cats groom themselves and they use their tongues. They have these very rough, sort of spiky tongues, and they groom their coats. And we know that we think that animals, cats that live in houses where people smoke, they are more likely to develop oral squamous
Hmm.
cell carcinoma
Oh,
because the residue from tobacco smoke is on their coats.
wow. Hmm.
So that's a gee whiz. So we have
Yeah. Yeah.
some questions from the chat now. Is there, I'm curious if there might be ramifications for cats on bisphosphonates for hypercalcemia. Those patients probably live longer than the patients on bisphosphonates as a palliative treatment. Yes, certainly we see cats with idiopathic hypercalcemia. Um, Mostly, I have to say that the internists treat these cats and not the oncologists. We certainly have some patients. We use a lot of chia seeds to treat idiopathic hypercalcemia in cats, and it's actually quite effective. I can't say that I've used a lot of bisphosphonates to treat hypercalcemia in cats. Uh, Jonathan, any experience at all in that area?
Not in particular, but is something that I wanted to comment when Dr. Neugarten and I were throwing this around a little bit. That this kind of idea is kind of the degree of necrosis that he was mentioning. It kind of came to mind for me with radiation-induced necrosis of bone and tumor when we're treating um, uh, um, patients with oral tumors with radiation. Obviously, a very different disease process, but kind of the same result of kind of the challenge of what do you do with kind of just lytic bone there. Um, and obviously very different because our vascular supply is disrupted with the radiation therapy. Um, but no, for bisphosphonates for cats, I don't have too much experience with that personally.
Yeah,
Speak
and
to.
there's a couple questions here about that, but these are really good questions for the internist, so I'm not gonna throw those out there just because Jonathan and I really just treat cancer. So we have a fantastic internal medicine, a very robust internal medicine team, and they are plagued with treating these chronic diseases. So anyway, let's see what else we have. I was going to talk a little bit about one of my favorite topics, which is viral carcinogenesis, which you brought up a little bit with HPV. And, we do have, not that HPV is a retrovirus, but we do have our own retroviruses, not so much documented in the dog, but certainly documented in the cat with feline leukemia virus being a big precursor to feline lymphoma, which is the most common disease that we see in the cat here, certainly. But could you talk a little bit about sort of what's changed in head and neck cancer, what the patient sort of used to look like and what they look like now, and
Yeah,
prognosis?
for sure. Yeah. So if we look at the overall 5-year prognosis of oral cancer, it's about 68%, about 68 to 70% of 5-year survival. We've gotten a lot better. I mean, we've gotten better with our diagnosis, we've gotten better with our treatment, we've gotten better with our imaging, and we've gotten better with the ability to be able to perform microvascular surgery and rehabilitate these patients. So we certainly using technology and the ability to go to the leg and reconstruct them. Whereas years ago, we did not have microvascular like we do now. So it was much more of a debilitating process. Still, it's not, it's a long recovery for these patients. But with a 5-year survival rate of 70%, it's beats the alternative, if you would. Um, but certainly, and it's also a matter of the risk factors, as we know. Are they going to stop smoking? Are they going to really be on the alcohol? But certainly there is a subset of patients that we don't know that why they develop these oral cancer. We see patients who don't have risk factors of smoking or alcohol. Are they around? Is there secondary smoke, as we know? Is that a risk factor? Certainly, I think secondary smoke is a risk factor. But one of the big things that we can't control also is genetics. So, it's we've gotten much better in our diagnostics, much better in our staging and our protocols, and in our chemotherapeutic. So 70% is our overall number, though, and certainly when we look at tongue cancer, it's about 80%. When we look at lip cancer, it's over 90% on the survival side, and floor of mouth is about 75%. So site specific certainly has gotten better because I think a lot of that is where and how quickly they're getting into our hands to be able to get them taken care of.
Do you think prognosis is better now, though, because more are associated with HPV, and HPV induced squames actually carry a more favorable prognosis?
I think so. I think certainly, and I think also access to care for some people, right? I think people are now getting more and more into the dentist. I think more and more cared about their. I'd like to believe that they are, that people are more conscious about their care.
Mm.
So certainly, um, eh, HPV certainly has played a bigger impact for us, and I think the outcomes on some level are better with that as well.
Okay, I'm going to jump to a veterinary question, which will make Dr. Ferrari and I laugh. Fascinating stuff on the human side. Very mundane question for the IHC for pets. Is IDEX better than Antec for IHE stains offered? Dr. Ferrari, you take this one away.
Well, I think that Dr. Liebman and I have been on a bit of a journey trying to
Quest.
investigate a little bit more about where are the stains being run, what is IDEX's involvement in it. We use IDEX personally at our hospital. And
Jay,
correct me if
just for,
oh yeah.
let me just interrupt. Jay, just so you know, these are the two big veterinary labs, commercial labs, IDEX and Antech, that we mostly use.
Yeah.
Sorry, go ahead, Jonathan.
And I know some dentists and oral surgeons that send samples to SOPA, which is the oral pathology group. I actually don't think they're taking new clients at this time. I think they had a staffing change. But regardless, I think that Nicole and I learned that IDEX, when you run IHC through them, kind of actually just acts as a middleman, if I'm not mistaken, and the stains get or the slides get sent to it is over to CSU, right, Nicole?
It's
And then it,
CSU or
yeah,
Michigan State,
right,
and so the process is really
yeah.
prolonged.
I don't know if Antec runs it in-house or if they do the same thing, if
I
they're kind
doubt
of
it.
the middle managers, in which case they should both have the same offerings. With the similar inefficient pathway of you order it through one of these, you know, really third parties at this point for what we're talking about, and then it gets sent out to the university, it gets run, and then it gets sent back to the pathologist to read. Which is just very interesting because I think I didn't understand that flow until we've kind of asked some questions about what happens when we order IHC, where does the request go and how is it run? So I don't think Antec versus IDEX is going to change in terms of, offerings. It's just up to the pathologist who decides what they would recommend running. And if the if the IHC report or kind of readout is never making or isn't making full sense with the clinical picture of it, we sometimes say, hey, are there other stains you would want to run? And they'll say, oh yeah, I was thinking about this too, but didn't do it in the first batch. Let's run it at a second batch. So always worth a conversation with the pathologist if there's ever any question. They tend to be pretty motivated to get you the right answer and to be a part of this you know, quest to get to the bottom line.
I should have never asked because he said 2 to 3 days, and that made us very sad. So we're on a quest to fix it. So stay tuned. Anyway, I think that's about it. Unless anyone has any last comments, I just really want to thank both of you for being here. This was great, really. So informative, and I personally loved it. So thank you all for joining us tonight. Please click the link in the chat box or scan the QR code to submit your CE credit for requests. Certificates of attendance will go out on Wednesday, November 20th. And tomorrow's topic will cover meningiomas, and we'll be joined by Dr. Catherine Beal from Cornell and Dr. Rachel St. Vincent from here at AMC, and we hope to see you there. Thanks, everyone.
Thank you. It was a true pleasure and honored. Thank you. Thank you, Nicole.
Thanks, everyone.